Please welcome Dr. Sarah Safadi, who is one of the valuable member of our hereditary GI team, who's going to talk to us about the GI risk outside of the colon. Thank you.
Can I take the mic and go there? Sure.
Well, hi everyone. Is it working? Can you hear me well? Good. I'm Sarah Safadi. As just mentioned, I'm one of the gastroenterologists here. I'm sure I've seen many of you in clinic or in endoscopy suite at some point. And because I'm a gastroenterologist, my objectives for my talk are going to be the gastrointestinal cancer risk in Lynch syndrome. We're going to talk about some of the alarm symptoms that you need to look out for and reach out for. And we're going to talk about the guidelines about this and understand together what the screening plan should be. The gastrointestinal tract or the GI tract starts from our mouth and goes all the way down to the rectum. It involves the esophagus, the stomach, the small intestines, and the colon. There are also two organs outside of that that are still part of the GI tract, which are the pancreas and the liver. You all are very familiar with the colon cancer risk in Lynch syndrome, and you heard a lot about it today. So I'm just going to mention it briefly because I don't want this to be very repetitive. But it is the most common cancer in Lynch syndrome. And I'm going to continue with the theme of the day, know your genotype, because the cancer risk is different according to the genotype that you have. And that usually guides the screening that we're going to do for you. So if you're someone with MLH1 or MSH2, the cancer risk is usually the highest here in terms of colon cancer. And because it starts median ages around mid-40s, we usually recommend that we start screening colonoscopies between 20 and 25 years of age and to be repeated every 1 to 2 years. However, if you're someone with MSH6 or PMS2 mutations, the risk tends to be a little bit higher. And the colon cancer tends to start a little bit later in life. So we don't have to start screening until you become between 30 and 35 years of age. And this can sometimes be relaxed up to 3 years instead of 1 to 2 years, but again, depending on your personal risk factors. So I'm going to spend the rest of the time talking about the other gastrointestinal cancer risk beyond the colon. I'm going to take you back a little bit. Dr. Stoffel mentioned earlier Dr. Worthen, who was the very first doctor who identified the first family with Lynch syndrome over 100 years ago. And in that family, he noticed that 3 members had stomach cancer. At the time, he thought that stomach cancer is the 3rd most common cancer in Lynch. However, later on, we found out that yes, it can happen, but it is not the 3rd most common cancer in Lynch. And throughout the 20th century, there has actually been a decline in the stomach cancer in general population as well as people with Lynch syndrome. So if we look at the lifetime risk of someone without Lynch developing stomach cancer, it is close to 1%. But for people with Lynch syndrome, again, it varies according to the genotype that you have. But the highest risk we have is up to 9% in people with MSH2. There are different risk factors that we know of that can increase your risk of developing stomach cancer. One meta-analysis looked at 14 studies that included almost 30,000 people with Lynch syndrome. And they identified that being a male can increase your risk of developing stomach cancer. And if you have a family history of someone, a family member who had stomach cancer before you, that can also put you at higher risk to develop stomach cancer. H. pylori bacteria, some of you might be familiar with that word. We're going to talk about it in a little bit. It is one of the risk factors as well for stomach cancer. And when they looked at the different genotype, they found out that people with MLH1 and MSH2 have higher risk of developing stomach cancer. Some other risk factors depend on the ethnicity or where you came from. Like Asian countries tend to have stomach cancer more than North America. So if you have ethnicity from those areas, we worry more that the cancer risk for stomach could be higher. Older age is a risk factor, as well as some precancerous changes that we can see on the stomach biopsies. So what about the small intestines? Small intestines are much longer than the stomach or the colon. They're around 12 to 20 feet long. But the good news is that if cancer was to happen, most of the time it tends to happen in the first part, what we call the duodenum, or the last part, which is the terminal ileum. And this is good news because these two parts of the small intestine are usually reachable with the scope when we do your procedures. So looking at the risk, lifetime risk of developing small intestinal cancer in general population, it is much less than stomach cancer. It's around 0.3%. And in people with Lynch syndrome, again, it varies according to the genotype that you have, but it can reach as high as 11% in MLH1. So now that we know there could be a possibility of cancer in the stomach and small intestines, the main question is, what can we do about that? And I'm sure you all are familiar with upper endoscopy because you all have done at least one of these. It is the procedure where we're allowed to put a scope down your mouth to take a look at your esophagus, stomach, and the first part of the small intestines. In terms of the stomach, thank goodness, polyps in the stomach are mostly benign, unlike the colon, where they're mostly precancerous. But it's important to do a very good exam of these polyps and make sure there are no precancerous features there. We don't need to take them all out or biopsy all of them, but a good gastroenterologist can take a good look at them and biopsy the ones or take out the ones that look suspicious. And even if we don't find polyps, even if the stomach looks normal, it is still important to take biopsies from the stomach because that can help us identify things like H. pylori bacteria or some precancerous changes. H. pylori bacteria, thank goodness, it's not as common in North America, but it is more common in some other countries, Asian countries, some developing countries. So if we visit these countries, we might sometimes get H. pylori bacteria from there. It can live in our stomach for many years. In lots of people, it may not show any symptoms, but sometimes it can lead to chronic gastritis, which is inflammation of the stomach. It can lead to ulcers, sometimes even lymphoma or stomach cancer. And that's why it is classified as class 1 carcinogen. So it's one of these things that we want to look for and treat it if we find it to decrease other risk factors for stomach cancer. And there are different pathways of why stomach cancer develops in the stomach. The most common one goes through some precancerous changes that we can sometimes identify with these biopsies, which can help us risk stratify or know your risk of developing stomach cancer to do more frequent upper endoscopies. So since you're already doing these upper endoscopies every couple of years, research has stopped and asked the question, is it actually helpful? Are we making a difference by having you go through these endoscopies? One meta-analysis looked at 9 studies that included over 2,300 people with Lynch syndrome. And those people underwent over 7,800 upper endoscopies. They found that the detection rate for cancer was close to 1%, for high-risk lesions was over 4%, and for clinically actionable findings is over 6%. So in short, this tells us that yes, we can find things through upper endoscopy, and sometimes we're able to do some things through the upper endoscopy. And another study was done on a German registry of people with Lynch that included almost 1,100 patients with Lynch who underwent over 5,000 upper endoscopies and found 49 stomach cancers. That study showed that if we do these frequent surveillance upper endoscopies, even if the person was to have cancer, most of the time we were able to find it at an early stage. While when they looked at people who were symptomatic before having the upper endoscopies, the chance of them having advanced stage was higher than the others who went through surveillance. Another question that this study looked at is presence of family history. And they found that almost 70% of the people who had stomach cancer did not have family history of stomach cancer, which means even the ones without family history may still need surveillance for that. So when should we be starting upper endoscopy? And how often should we be repeating this? I'm sure you all have heard a lot today about NCCN guidelines, the National Comprehensive Cancer Network. These are the ones that we most commonly follow because they're updated every year. And according to the NCCN guidelines, they recommend starting upper endoscopy between the age of 30 to 40 and repeating it every 2 to 4 years. And they recommend taking biopsies from the stomach at least on the first upper endoscopy. So in summary, when we talk about the cancer of stomach in Lynch syndrome, or the cancer of small intestines in Lynch syndrome, the good thing is that the lifetime risk is low. It's not like colon or uterine. And it will take a lot of negative exams to find one cancer. But in my opinion, the benefits still outweigh the risks because it's done usually along with the colonoscopy. You're already being put under. It mainly adds a few extra minutes to your exam to allow us to take a good look in your upper GI tract and try to prevent cancer from happening or catch it early if it was to happen. So what about the pancreas? It's a question I get asked a lot in the clinic by Lynch patients. You all are familiar with the pancreas. It's the organ that sits in our abdomen behind the stomach. We do know that people with Lynch have higher risk of developing pancreatic cancer compared to the general population. And we do know there are risk factors for that, including chronic smoking, chronic pancreatitis, being obese, having diabetes. But the most important risk factor for pancreatic cancer is family history. And there are many studies that have been done on that. And one big study showed that if you have a family member with pancreatic cancer, you have 2 times more likely chance to develop pancreatic cancer. And for each family member, you have twofold increase in that risk. So the more family members you have, the higher the chance of you developing pancreatic cancer. And in terms of screening guidelines for pancreatic cancer, they depend on the presence of pancreatic cancer in the family. So NCCN guidelines recommend if you have more than one first or second degree relative with pancreatic cancer, then you will need screening, and that usually starts at the age of 50. However, if your family member got the pancreatic cancer at a younger age than 50, then the guidelines recommend starting it 10 years before the age of diagnosis. And this is a little bit different between guidelines depending on the relation of the family member to you, whether he's first degree relative or second degree relative. And that matters because our insurance companies follow these guidelines in terms of coverage for these procedures. But what I need you to know is that the closer the family member is, and the more family members you have with pancreatic cancer, the higher the chance of you developing it. So what are the benefits of doing pancreatic cancer screening? Because pancreatic cancer has a high risk of dying, because it's usually diagnosed at a late stage, spread stage, catching it early can actually save lives. And screening can allow us to catch it before it has already spread. And there are some precancerous spots in the pancreas that screening can help us catch before they even turn into cancer. And the way we screen for pancreatic cancer is using a dedicated MRI called MRCP or an endoscopic ultrasound. And this procedure is similar to the upper endoscopy in terms of you're being put to sleep and there's a scope going down your mouth. But that scope has an ultrasound attached to it that can go inside and give us a better view of the pancreas. And even if there is a spot in the pancreas, that procedure allows us to take a sample of that spot to see if it's cancerous or not. So what are the downsides of pancreatic cancer screening? Because we don't do it for everyone, and It's not as great as colon cancer screening. The thing is with pancreas, there's a high rate of incidental findings. We sometimes find spots in the pancreas that are in the gray area, that it's hard for us to know, even with the MRI, even with the EUS, whether this is cancer or not. It's just in that gray area that we're not sure. This could turn into cancer, but it's in the gray area. But when we find that during the screening process, we're going to have to recommend surgery because we don't want to take the risk of that developing into cancer. And of course, pancreatic cancer surgery is not a simple one. It does have risks associated with it, with unclear benefit if that spot ends up being just benign. And even just going through the screening procedures, like the endoscopic ultrasound, has its own risks of complications associated with it, whether it's the anesthesia risk, the biopsy of the pancreas, and so on. Not to add the psychological stress that we're putting you under when we say you need to do pancreatic cancer screening every year. So, in summary, the lifetime risk for pancreatic cancer is low, but if you have a family history, then we do recommend surveillance, and it's always better to do that through an expert center where they're more familiar with the pancreas and can add all of these other procedures. So the last part of my talk, I want to focus on the things that you need to be aware of and the things that you should alert your doctor for. Any new symptoms. If you ever notice that you're throwing up blood, if you ever notice there is black tarry stool in the toilet, if you ever notice there is bright red blood or maroon colored blood in your stool, these are things that we would want to know about because these could be signs that there's something going on in your GI tract. Other symptoms, if you ever start developing new onset nausea, vomiting, indigestion, or feeling full as soon as you start eating, and these symptoms are persistent, they're not going away, it's been a couple weeks, they're not going away, we should definitely know about this because this could be a sign that there is something serious. Most of the time it's not, but we do not want to miss cancer if it was happening. And there are some blood tests. You're getting annual blood work with your primary care doctors. Sometimes you're found to have low iron level or low ferritin level, which is the iron storage form. This is another sign that can tell us there could be something wrong in your GI tract. There could be a tumor in the GI tract. So we would want to know about that. Hemoglobin A1C level, which is the test for diabetes. If you're suddenly developing diabetes, if it has been trending up quickly, this can be an alarm that, oh, there could be something in the pancreas going on. So we would want to know about that. Elevated liver enzymes is the one that most commonly happens. Most of the time, it's not alarming. It could be related to alcohol use or fatty liver disease. These are usually the most common causes of this, but we still want to know about it because sometimes there are tumors that could be leading to this. So the take-home points, you need to know your genotype again and again and again. Watch for the red flag symptoms. Continue surveillance upper endoscopy every 2 to 4 years. And know your family history, especially when it comes to pancreatic cancer. Thank you.
Speak out of this.